Good afternoon, and welcome to HIT Policy Update, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Lexmark. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. Our Managing Editor and Director of Social Media, Kate Gamble, is hosting a tweet chat that you can see in the media viewer screen on the right-hand column of your console. If you want to participate, just open a separate browser or use your phone and use the hashtag HSCIOchat. So that's in your media viewer. If you want to ask a question at any time during the event, use the Q&A box on your right-hand side. Type your questions in, leave the default set to all panelists, and go ahead and send those in as they occur to you, and we'll take them later in the program. And you could download the deck using the URL on your screen, and we have a shortened URL at the bottom of all slides. Just so you see how we're going to spend our time today, first we're going to go 25-30 minutes with Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. Then we're going to hear from our sponsor, represented by Darren Sinkler, Healthcare Industry Director with Lexmark. And then we're going to have our Q&A with Dr. Halamka. So without further delay, I'm going to turn it over to our good friend, Dr. John Halamka. Thanks for joining us.
Well, thanks very much, Anthony. And, of course, today Anthony has given me the challenge of summarizing the 962-page MACRA regulation so that you don't have to read it. And so we're going to try to set the level of granularity so that it's the high points without getting in too much of the onerous detail, but we will have Q&A, so should you have any specifics we don't cover, please ask questions. So today, we'll cover MACRA, but there are a couple of other things that are happening in the ecosystem that we should talk about, which is we've had an era of meaningful use. We've had an era of ICD-10, the HIPAA Omnibus Rule, and the Affordable Care Act over the last few years, the Obama administration. As we see the end of the Obama administration, what we'll also see, I suspect, is a pause of about 12 months between administrations. Whether it's Democrat to Democrat or Democrat to Republican, there's going to be a pause as you see the folks who are the political appointees submit their resignations on January 20th. Remember, career appointees will still stay in place. You'll see a lot of acting and temporary personnel during the transition. And I suspect during that year you'll see some great leaps forward in the private sector as the government stops its regulatory pace for a bit of time. So today we also will cover some of the things that Apple and other companies are doing in the private sector that you should find interesting. And then I have many colleagues at CMS, and I've asked them for meaningful use updates and advice, so I'll pass that along to you. So let us start on MACRA. And so I recognize that MACRA probably has one of the world's most challenging acronyms because it is the Medicare Access and CHIP Reinvestment Act. And what is it exactly? What the folks at CMS, who are very well-meaning and very smart, tried to do is to consolidate the heterogeneous programs that we've seen evolve over the last several years. The Physicians Quality Reporting System, or PQRS, the Value-Based Payment Modifier, which is sort of a reflection of whether you're providing value-based care that's cost-effective and high quality, the Meaningful Use Program, and to try to create a single set of regulations, a single set of processes, a single set of submission requirements that align these three disparate programs, PQRS, Value-Based Modifier, and Meaningful Use. It's a pretty noble goal. And when I have published a few articles about MACRA, what some folks have said is, John, you know, are you suggesting we all collectively slit our wrists over this thing? No. All that you will hear in my remarks today are that the 962 pages, although extremely well thought out, are a bit complex for an average clinician seeing a typical patient on a given day. Doctors are smart people, but I think as humans, it's very challenging for us to remember more than about 3 things at a time. And so imagine that, I see Anthony in clinic and I can say, okay, don't order redundant lab tests. Make sure and explain to Anthony what his condition is and his medication side effects, and ensure that there's a clear care plan. Let's say that those were the 3 goals I had for every single patient that I saw. I could do that. I could probably achieve a pretty good outcome. What you'll see in the 962 pages of MACRA is that it asks clinicians to reduce cost, enhance quality, engage in quality improvement activities in their practice, hit 6 to 8 meaningful use IT requirements, and do this using an 80-variable nonlinear differential equation while they're seeing the patient. You could argue that's a little hard to relate the regulation to the activities of a clinic visit. And so let's go through the details and you'll see what I mean. Again, no criticism. We shouldn't slit our collective wrists. We should just ask ourselves, can we tie this regulation to changes in physician behavior in a single clinic visit? So a couple of high-level comments about MACRA. It does consolidate those 3 existing programs, as I said, so if you're already participating in the Physician's Quality Reporting System and the Meaningful Use Program, then the merit-based payment incentives of MACRA actually may be a consolidation, may be a little easier for you, and it certainly offers some flexibility. If you aren't participating in, say, the Physician's Quality Reporting System at the moment, you really should start in 2016. MACRA takes effect in 2018 with a measurement period, initial period in 2017. If you're not doing quality reporting in 2016, you'll be so behind the 8 ball, so behind the curve in just getting ready for the 2018 change, you'll never be able to make it. So what folks at CMS have said is, recognize when you look at all the programs that exist in the government today for eligible professionals, that's meaningful use, plus the value-based modifier and PQRS, there's conceivably up to 8% in penalties now. Under the MACRA MIPS regulation, you're going to have a cut of 4% if you don't participate. So in some ways, it's some forgiveness. And CMS has said you really, if you want to try to avoid that 4% minimum cut, get involved in the Physician's Quality Reporting System this year. Even if you're going to do a bad job in the Physician's Quality Reporting System this year, still get involved so that you're ready for 2018 when it's really going to count. So what are these provisions of MACRA? As I say, it is combining lots of historical legislation regulation into one comprehensive program with quality and resource use or cost, practice improvement, and the Meaningful Use Program, which has now been renamed to Advancing Care Information. Now, let's look at what these details are, because this is going to be a little challenging, I think, for everyone to understand. Cost. As a physician, when I see a patient, I generate a bill. That bill for my Medicare patients is reimbursed, and Medicare has a full record of what it is I billed for. So this cost portion of the MACRA effort will actually be measured by Medicare based on the bills that are reimbursed. So think of this whole MACRA score as a complex equation that involves cost, quality, practice improvement, and advancing care information. So for cost, 10% of your total score is going to be based on the claims that you submitted to Medicare. You don't have to submit anything extra. You don't have to do an attestation. Medicare will figure out your costs for the measurement period and will give you a score, 10% of your total score based on cost. Now, what about quality? Well, here's a challenge. I have glaucoma, and remember, Anthony, I have no privacy, no HIPAA issues here whatsoever. I can share. It's open.
Okay.
I think that my ophthalmologist should probably be scored based on my vision quality as opposed to my smoking status. Oh, by the way, I don't smoke, never have. But remember, the Meaningful Use Program said every single meaningful use quality measure must be submitted by every single physician. And there's going to be a lot of measures that have absolutely nothing to do with the particular specialists like ophthalmologists who should be optimized to some other thing besides blood pressure, smoking status, and care plans or whatever. So what the proposal is under MACRA is there's going to be this pool of quality measures, and the physicians will pick the quality measures that are relevant to their specialty and practice and report on 6 measures. And so, okay, again, maybe that's going to be a good thing. And as part of your total MACRA score, remember 10% based on cost, 50% will be based on quality. So far, so good. Now, we know there's going to be a set of potential clinical practice improvements. Maybe you want to create an open access model that enables sick patients to schedule their appointment today, not 6 weeks from now. Maybe you're going to engage in secure patient-doctor communications using texting. Who knows? But the folks at CMS will offer you 90 potential options for clinical practice improvement, and you will be rewarded for selecting specific activities from that pool of 90. 15% of your total performance score will be based on clinical practice improvement activities that you document and report on. So we've got 10% cost, 50% quality, 15% clinical practice improvement. And then what used to be the Meaningful Use program, now 25% of your total score will be based on advancing healthcare information. And the kinds of things that have been derived from the Meaningful Use program, the Stage 3 criteria, will be such things as e-prescribing, security and privacy protection, patient and family engagement with educational materials, coordination of care, health information exchange, including the ability to send data to patients, and public health and clinical data registry reporting. So you'll see in the advancing care information, it's a lot of the same criteria as what were formerly in Meaningful Use Stage 3, but with a special focus on healthcare information exchange and interoperability, provider to provider and provider to patient. So you'll be graded on your performance in those particular areas, and that'll be 25% of your score. Now, here's where it does get a little bit complex. In the Meaningful Use program, it was all or none. If you had a criteria like, did you exchange information with other clinicians for 10% of your patients? If you did 9.5%, you lose. It was a pass-fail score, 10% or greater pass, less than 10% fail. And so the folks at CMS were asked, can't you give us partial credit? So they said, sure, let's do this. Let's come up with a point-based scoring system that looks something like this. What we're going to do is we're going to give you a set of criteria. We are going to then take each criteria and we're going to divide your performance, say, based on numerators and denominators by 10, and we're going to add everything together, and we're going to come up with a composite score for advancing healthcare information. So maybe you excelled at patient-family engagement but didn't excel at provider-provider data exchange, and this computed score, which is based on calculation of numerators and denominators, then all divided by 10 and all added together, will get you beyond a threshold. So not pass-fail, call it graded on a curve with partial credit. So again, that sort of in theory sounds completely okay, and you'll see on this slide that it's customizable, it's flexible, it's focused on a patient-family engagement, interoperability, it's very much aligned with everything else Medicare wants you to do, and, oh, by the way, there will be certain exemptions offered. But so think about everything that I've just said in the last couple of minutes. If you walk in to see a patient and 10% of your score for that encounter is based on how much money you spend in a claim, and then 50% is based on the quality you deliver, and then 15% is based on whether you did some novel clinical practice improvement. And now you have 6 to 8 meaningful use criteria, each of which is divided by 10 and then weighted and then added together, and then sum total of that is 25% of your total score. You can see what I've just told you is a 80 variable nonlinear differential equation that you have to keep in your mind every time you see a patient. And is any clinician really going to be able to do that? So I applaud the idea of trying to reduce cost, improve quality, improve your care, and engage in interoperability with flexibility and exemptions, et cetera. I'm curious to see in practice as this thing is implemented if it is just too many moving parts. And maybe what we're going to see is it's a flexible enough framework that EHR vendors will work with customers and come up with highly usable electronic systems that actually bake all this stuff into the electronic system so the clinician just does what a clinician does best, practice at the top of the license, be empathetic, listen to the patient, deliver great care, and the rest is magic. Or maybe it will require so much data entry and so much focus on process that a clinician will no longer be able to spend time actually making eye contact with the patient. Or as I've written about, maybe the solo practice will cease to exist because trying to comply with all this data submission and measurement and equations is not going to be possible unless you have the support of a very large organization behind you. So what we'll see is all the small practices close and multi-specialty practices, the Kaiser models, the IDNs, the ACOs become the only way healthcare is delivered in this country. So that's, I think, just the food for thought. Again, don't want to be a downer here, don't want to criticize any of the people who work so hard on this, just want to reflect on what we've done to ourselves.
Sorry.
No problem. So there you go, Anthony. That's MACRA and MIPS.
I like the phrase, what we've done to ourselves. Go ahead.
Well, how about this? It turns out that our friends at the Institute for Healthcare Improvement, Don Berwick and his team, have a statement, our U.S. healthcare system, or any healthcare system, is perfectly engineered to get the results it gets. So if we've created a 962-page regulation with a nonlinear differential equation with 80 variables, and you go to the doctor's office, and the doctor spends more time on the keyboard than touching the patient, maybe we've perfectly engineered the solution that we tried to engineer. I don't know. Could be. But it's clearly time, as I have written about, to look at all of this at a higher level, step back, and ask, what have we done to ourselves? Because maybe there are ways we could achieve the outcomes we desire that aren't so complicated. And here's an example for you of something the private sector is doing. 2 weekends ago, Tim Cook introduced at the Worldwide Developers Conference some additions to the Apple platform. And Anthony, I have no stock in Apple. I have no financial relationship to Apple whatsoever, so I say this as an objective observer, not in any way a beneficiary of Apple. The 3 products that Apple will include in iOS 10 for every one of the 820 million iPhones on the planet are Health Kit, Care Kit, and Research Kit. Health Kit is a mechanism of getting objective data from the devices in your home, your blood pressure cuff, your pulse oximeter, your glucometer, and that kind of thing, and sending it to your doctor or to other apps. So that's interesting. Certainly for home care, telemedicine, telehealth, that's very helpful. But what Tim announced, and it's a really interesting new idea, is that Health Kit will now be able to receive your entire medical record from any meaningful use certified EHR and keep it on your phone for you to securely manage. So if you look at this next slide, what Beth Israel Deaconess did is it literally in minutes, we modified our personal health record portal, our patient portal, to be able to, just like you download an airline ticket into the wallet on your iPhone, you can download your medical record and you can see an actual live Beth Israel Deaconess medical record, name changed, on your phone to carry with you to share with other clinicians, to share in an emergent situation, to share with family members, etc. And you can see it is the complete clinical document architecture specified by meaningful use, which includes problems and meds and allergies and labs and care plans and care teams and all the rest. Now, Apple chose, I think, fairly wisely not to replicate this data in the iCloud. And why did they make that decision? Jennifer Lawrence. Now, why do I say Jennifer Lawrence? And by the way, Tim Cook didn't say Jennifer Lawrence. It's me saying Jennifer Lawrence. If you remember about a year ago, Jennifer Lawrence gave her iCloud username and password to her secretary. Her secretary received an email from the Nigerian businessman asking for an urgent password reset. So that secretary then dutifully typed Jennifer's iCloud credentials into the web page of the Nigerian businessman. And next thing you know, all of Jennifer Lawrence's naked photographs from the iCloud ended up on the internet. The iCloud was not compromised. There was no hack whatsoever. It was a gullible human that gave away a username and password. So what Apple thinks, and I think it's probably correct, is that your medical record should be stored on the device you carry with you and only accessible with your thumbprint being placed on the phone sensor and not sent to a cloud where someone with a username and password could spread your medical data all over the internet. Now, who knows, someday this might evolve to some kind of family cloud sharing approach, but I think we need to learn a lot more about how patients use their medical records, how we protect privacy and security of medical records when it's on a device before we start doing cross-device or cross-family member sharing of the medical record. So with HealthKit, all the data from your home going to your doctor, and all the data from your doctor going to your phone. And that's great, but it's not sufficient, because as a doctor I can tell you, there are things that I can't know about you. You have to tell me. So, Anthony, how's your mood today? Is your caffeine consumption under control? Are you feeling good?
I am feeling good.
Oh, that's perfect. So only you know the answers to these questions. There's no device I can put in your home to measure how compliant you are with your care plan or how good you feel. And to my knowledge, there is no Nest product that measures your coffee maker's output and reports it to your doctor. I mean, these are all subjective measures. And so CareKit is designed for patients to answer questionnaires that provide information on mood, pain, wound healing, post-op course, things that the doctor and the care team need to know about you that only you can provide. So imagine this, because this is also true, Anthony. I was diagnosed a few months ago with essential hypertension. I inherited it from my parents, nothing I could do about it. So vegan diet, body mass index of 20, and I still have a high blood pressure. Oh, well. I was given beta blockers. Now, beta blockers are very effective at controlling high blood pressure, but they could also make you feel really awful because it's like having reverse caffeine. It could be very tired. So imagine this. HealthKit is gathering information about my blood pressure measurements, and so you can see 120 over 80, 110 over 70, all looking good. CareKit, oh, and I actually have energy. I actually feel good. I'm actually able to do all the things I want to do. And then finally, ResearchKit is the idea that patients can contribute their data to clinical trials or be actively involved in clinical research. When my father was alive, he had multiple sclerosis for about 25 years. He was very interested in participating in clinical trials and clinical research for new treatment, and would be very happy to contribute his information to databases and registries and be involved in studies. And ResearchKit would have enabled him to do that on his phone. So objective, subjective, clinical trials and clinical research all on your phone. I mean, to me, that's something that is very understandable. It adds value. And what could be simpler than simply, as you walk out of the doctor's office, all the data about your doctor's visit just appears on your phone. It's auto-magical. And so hence, you know, when you look at MACRA and some of its details and complexities versus some of the simplicity of what you're seeing evolve in the private sector, I just think we have to be careful we don't be overly prescriptive with regulation when we're in the midst of great private sector innovation. Now, speaking of regulation, I did ask my friends at CMS, who are, of course, not going to be able to talk about future regulations, but, you know, in general, offer advice on current regulations. MACRA, as I've described it today, is for physicians, right? It is just for eligible professionals or clinicians in general. It will be expanded beyond doctors to nurses and therapists and others, but it's clinician-focused. Meaningful use, remember, is both hospitals and physicians. So think of MACRA as the replacement for the physician side of meaningful use, but hospital meaningful use is still scheduled to go forward. So I asked CMS, you know, what should I tell people on this webinar? And what they said was, the last time that regulations were issued about hospitals was October 2015. And what it said is that in 2016, every hospital in America must attest to modified stage 2 criteria. And in 2017, you have the option of doing stage 2 or stage 3 based on the fact that many EHR vendors have not certified their products for stage 3 yet. I suspect hospitals in 2017 should just plan on stage 2 attestation. But then, at the moment, we're scheduled to have meaningful use stage 3 in 2018 for all hospitals, and so just assume that, yeah, you may not need to upgrade your software this year or next, but you better have it in place by 2018, because at the moment, you're probably going to have to attest to stage 3 in 2018, unless there is a MACRA-like regulation issued for hospitals, which could be, and therefore the meaningful use program, as it's currently written for stage 3, could be modified or sunsetted. So my prediction goes something like this. If you're a hospital, attest to stage 2 in 2016, attest to stage 2 in 2017, and probably bet, though it's a bit of a gamble, that by 2018, the Meaningful Use Stage 3 program will have morphed into something else that's maybe a little bit more like the MACRA for professionals. And you have some time to get your software upgraded. And I think the next couple of years, we'll see a lot of regulatory revision as we look back at what we've done to ourselves and decide whether, in fact, we need to focus more narrowly on things like interoperability and give physicians and hospitals more flexibility and more of an outcomes focus than, as we have with Meaningful Use Stage 2 and 3, a huge number of check boxes. That's caused a lot of frustration. So there you go, Anthony. You know, there's where we are with MACRA, the private sector, and meaningful use as I know it. And let me turn it back to you.
All right. Sounds fantastic. Appreciate the presentation. And now we're going to hear from our sponsor, represented by Darren Sinkler. So, Darren, thanks for joining us. Thanks for sponsoring.
Yeah, sure. Thanks, Anthony. And again, thanks, Dr. Halamka, for all your insights. Really appreciate it. For those of you, I know looking at the list, there are quite a few people who have been on the calls before, but there are some new folks. So I wanted to just take a couple of minutes to go over a couple of slides for you, introduce you and get you familiar with Lexmark. You know, many of you probably know Lexmark from its excellence in printing and print technologies, and probably many of you have our copiers and printers in your facilities today. But what you may not know is that we're also a software company. We have a standalone software division within healthcare at Lexmark. Lexmark's really made some key investments in leading healthcare software technologies over the last 4 or 5 years in 4 primary areas. One is in content management, which you may also know as document imaging and management. The second is vendor neutral archive. The third is viewer. We have both a diagnostic and a referential read viewer, zero footprint viewer. And then the fourth is we have a whole host of connectivity and capture solutions for radiology and cardiology and all the other ologies. So those four primary buckets really encapsulate our approach to your entire enterprise content management, all the things that float around a patient care process that you need to make care decisions daily. We have tools and solutions for you. I won't necessarily read the slide to you, but as you can see, and add to further educate you on who Lexmark Healthcare is and our position in the marketplace, I'll just point out a few key statistics. You know, number one, I guess I would say is we're always historically in the top 3 best in class, which I know is important for you all when you think about your purchasing decisions and who you want to partner with from a vendor perspective for both VNA and ECM. And in fact, I checked it a couple days ago, and I think we are #1 vendor for vendor neutral archive. So that's a good thing, and we'll continue to push and maintain our #1 spot there. The second I wanted to point out is we have over 220 unique Epic customers that are using our solutions in one way or another, whether it's our vendor neutral archive, our viewers, our content management solutions, or a combination of all of them. We definitely have the Epic market to some degree. And I don't want to discount Cerner or Allscripts or some of the other EMRs are very important, and we have some good partnerships and integration points with them too, but I just wanted to highlight Epic in particular today. And then I also wanted to highlight that we've migrated over 300 million imaging studies to date, and that continues to move and improve every single day. So when you think about you know, who we are as a company and a vendor and who we compete with, you'll see some of those names here. The one thing that I wanted to point out is that experience really does count, and we've done it more than the other folks. And when you're partnering with a vendor, it's not all been pretty. We've gone through, you know, learning curves and all these other things, both domestically and globally. But we've certainly learned quite a bit by doing this so many times over and over. So I like to stress to everybody that experience does count. What's driving the need for vendor-neutral archives and content management solutions? Some of the things that Dr. Halamka touched on earlier, grabbing information, storing it, being able to share it, being able to access it both inside a hospital and outside of a hospital. So those are the things that we do really, really well, and we can help you do those things. And it's not just accessing on your Apple phone or on your on a PAC station, but it's also accessing from an iPhone, from a tablet, from a iPad, or directly inside the EMR. So we have lots of different ways to store, manage, route, and view information. Why VNA? I get asked that quite a bit, almost every day. Why should we go with you guys, or why do I need a vendor-neutral archive? Why can't I just stay with my PACS archive? I get that question quite a bit, and as you can see on the left-hand side, I mean, the PACS archives, they're good at what they do inside their own space, but what you typically will find is that you have little pockets of information everywhere throughout your facility, and you have a lot of vendor lock, a lot of vendor block, which are alive and well, and you cannot get access to the information you need, and you cannot share it easily when you're in that type of environment. The VNA just simply does helps you out with all of that. It stops the vendor lock, it helps you integrate with that EMR, and basically at the end of the day, you'll own your own data. You can access it, you can migrate it, you can move it, and you can share it with anybody who needs to see that information. These are very important pieces to meaningful use in the past and in the future. I won't highlight our zero footprint viewer that's on our website. You can go ahead and check it out and play with it. It's got some interactive tools, but it's state-of-the-art, it's cutting edge, and it's used by some of the biggest radiology and cardiology facilities in the country. I talked about connectivity, and some folks don't know what that means, but I like to say that we're really like the Swiss Army knife for your ologies. So whether you need to connect things, capture video, store video, view video, burn CDs, I mean, we've got a little bit of everything. And my guess is you probably are using our PACS Gear suite of solutions in your facilities today somewhere. We're in about 3,000 hospitals today, so quite a few different products there. And that's it. Anthony, I'll wrap it up there. I just encourage folks to go to our website, check it out, learn a little bit more about Lexmark Healthcare Solutions. We're going to be at SIM this week, tomorrow through the end of the week out in Portland, and of course we'll be at RSNA and then HIMSS in the spring. So appreciate the time, and thanks, Dr. Halamka.
Well, thank you, Darren, and we appreciate your sponsorship and support. All right, now we have time for our Q&A. I have a few questions that have already come in. Go ahead, send your questions in the Q&A panel and leave the default set to all panelists. We'll take a look at those. So, first question for you, Dr. Halamka. With the recent report that healthcare costs go up with health system consolidation, do you think MACRA will actually cover the costs required to meet the objectives?
Wow, that's a tough question. But look at it this way. Right now, in much of America, we have a fee-for-service system. Talk about engineering a result to get what you're going to get. If I pay, Anthony, you to run more webinars, you're going to run more webinars. If I tell you, I'm going to pay you $1,000 whether you run one webinar or 100, you're going to run the right number of webinars, not too many and not too few. And so the hope with MACRA is if we start paying for your performance and your outcomes, that you're going to order the right number of tests, not too many, you're going to have the right number of hospital days, you're going to have new alignment of incentives to do things like telemedicine and telehealth, keep patients well in their homes, because you're no longer paid for hospital days, you're no longer paid for MRIs, you're given, say, a fixed dollar amount for the wellness of the patient. So, yeah, you are correct. We're going to have this ugly tweener period where we're going to have some fee-for-service and some value-based purchasing and some risk contracts at a time when you're going to have consolidation, and consolidation may lead to escalation of prices. But I think eventually what we'll get to is a healthcare system that's better coordinated and is paid for the outcome, and therefore, hopefully, the cost curve will bend, will slow.
Well, question from me before we get to the next audience question. We've discussed this in a lot of different webinars, under a lot of different topic headings, the idea of a health system moving itself rapidly toward a pay-for-value world when most of their reimbursement still lies in a fee-for-service world. And essentially, if you're very good at what you're doing, you're significantly reducing your reimbursements. So what are your thoughts about that, about sort of making sure that a health system stays in step in terms of its contracts with what it's doing on the, the clinical side to give better care?
Sure. So Massachusetts has already gone through a lot of this transformation, because we've had this idea of universal health care coverage for 10 years, and our private insurers are already doing value-based contracting, alternative quality contracts, that sort of pay-for-outcomes type stuff. So today, as I sit here in June of 2016, Beth Israel Deaconess has $1.5 billion, with a B, dollars in value-based purchasing contracts. We already have gone through it, and of course the hard question is, when do you leap? Because if you wait too long, your competition will eclipse you with value-based purchasing capabilities. If you move too fast, as you say, you sacrifice your fee-for-service business. So I think our delicate dance was keep fee-for-service going until there was a tipping point where you'd say you're at about 20% of your contracts being value-based purchasing contracts, then go whole hog into value-based purchasing. And the CEO will either be praised as a saint or fired based on whether they jumped too early or too late. Right. But that was what we did, around 20%, and then you make your transition.
Very good advice. All right, next audience question. Curious as to how you interpret the required measures for, I guess this is modified stage 2, reporting in 2017 with the 2014 edition EHR criteria. If the public health immunization measure is the only proposed required public health measure? You could probably see that in the Q&A box if you want to read it again.
Yeah, no, I mean, I completely understand it. So So this is, again, sort of our challenge. If you look at the fact that there's a 2014 edition certified EHR, which has a certain set of capabilities. You have a 2015 certified edition EHR with certain capabilities. You have Stage 2, which offers certain public health options, Stage 3, certain public health options, and MACRA, which gives you a bonus point for certain public health transmissions. So I think we are going to have this fascinating issue of instead of having one plan with one version of software and everybody on the same schedule, we're going to have multiple plans with multiple versions of software and multiple people on different schedules. So I guess my advice on the immunization side of things is a meaningful use Stage 2 certified EHR should be capable of submitting data to an immunization registry, and if your local immunization registry isn't capable of receiving it, then you file a hardship exemption. And my understanding is that CMS has been extremely generous with hardship exemptions where you can send, but there's no receiver to receive.
Okay, very good. Let's talk to me a little bit about, so we have all this MACRA stuff that you described in detail. What do you think CIOs, hospital CIOs, what should their takeaways be from all this MACRA stuff in terms of supporting physicians that work in the hospital?
Sure, and of course, this, Anthony, is probably one of the things that keeps me up at night the most. Because I'm not sure about the people on this call, but do you think your CEO is going to call you into the office tomorrow and say, you know what we need? We need an omnibus, population health-focused, big data analytics solution which incorporates interoperability and provides us the capacity to do value-based purchasing across the community. If you find a CEO like that, hey, let me know. I'd love to work for that person. In fact, what's going to happen is the CIOs are going to have to skate where the puck is going to be. You're going to have to guess. So if we said MACRA is a component of cost, well, is there something you can do in your EHR system, such as show each clinician at the point of ordering each ordering option with a cost associated with it. Oh, I didn't realize that erythromycin is 25 cents a pill, Zithromax is $2, and Biaxin is $20. Oh, okay. I will change my behavior because now I have some understanding of cost. That's something you could do. For quality, one of the things we've tried to do is build alerts and reminders such that every time a patient shows up, we pre-compute what quality metrics are necessary for that patient and show the physician a little to-do list. You know, while the patient's here, make sure and give them a flu vaccine. While the patient's here, schedule an eye appointment. And therefore, our quality scores, we think, will be okay. Make sure your EHR will support some kind of clinical practice improvement activities, like the example that I gave you of doing better patient-family engagement, some kind of electronic workflow that is going to be innovative. And for advancing care information, I think you can look at the criteria, and it's really mostly meaningful use Stage 2 types of stuff anyway. Just make sure that your clinicians have changed their behavior so they do well in these criteria. Overall, I think we know the future is going to be based on value, and so putting in place a population health tool that enables you to get the right care to the right patient at the right time is fairly important. And what we did, we built it ourselves, but I'm sure there are plenty of commercial solutions out there. We enroll a cohort of patients by disease, say diabetics, into a care plan. The care plan says eye exam, foot exam, Pneumovax, and hemoglobin A1C less than 9, something like that. Our care managers are able to look at gaps in care for that cohort and have a queue that they follow, very much like a customer relationship management system, the kind of thing a salesperson would use. So they're managing the case, making sure they get everything in that guideline or protocol done over the course of a year. So if you've done something like that, you probably now have the tools in place for dealing with the value-based purchasing requirements of the future. All
right, I think we have time for one more question. You wrote recently regarding one of the big, it might have been MACRA, one of the big releases of, and you broke it down in your blog, and you concluded it by saying, if we don't change direction, it might be time to look for a new line of work for physicians.
Right.
I'm sure you remember that line. It was it was very stark, and do you still feel that way, or have you softened?
Well, I trained in medicine in the 1980s. And back in the 1980s, what we were focused on was the science of medicine and the empathy we would give to our patients in helping relieve their pain and cure their illnesses. Today, I could argue, don't even bother teaching the Krebs cycle, teach the revenue cycle, right? Because the nature of practice is such that many national surveys, AMA, AHA, others have done them, show that 40% of clinicians want to leave the profession today because of the overhead and the burden that is far beyond the relieving of pain and the curing of illness. The compliance and regulatory complexity of being a doctor is just extremely frustrating. So that's where not a single one of the proposals, ICD-10, meaningful use, MACRA, MIPS, ACA, is inherently bad. But the sum total of all of them is very analogous to the old story about boiling the frog, right? If you put the frog in water and you slowly increase the temperature, the frog doesn't notice until the frog is cooked. If we keep adding regulation after regulation after regulation without recognizing the sum total of the burden, all our physicians will be cooked. That's the word of warning.
Wow, that's very good time to end, and a perfect closing. So I want to thank you, Dr. Halamka. I want to ask everyone to please take a moment and answer our post-event survey when you close out of your WebEx window. I want to thank, again, Dr. Halamka and Darren Sinkler and Lexmark for sponsoring today. As I mentioned, you'll receive an email when our archive recording has been posted to our YouTube channel. For those of you who have the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so make sure you let CHIME know you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox. And if you need a certificate of attendance for another CEU program, you can use the final slide in this deck. And please go to our website to view our upcoming schedule of webinars. So once again, I want to thank Dr. Halamka, Darren Sinkler, Lexmark, and all our attendees. Everybody have a wonderful day.
Thanks so much.